Good morning, I am Dr. Henna. The topic for presentation today is examination of cutaneous lesions. Examination of skin lesions form the fundamental part of clinical dermatology. It involves inspection as well as palpation of the skin lesions. So let's start with inspection. On inspection, look for certain features which will describe a characteristic skin lesions. The components of description of skin lesions include number, whether it is well defined or ill defined, color of the lesion, shape, morphology, border, size, surface, symmetry, site, distribution, and pattern. Next. The skin lesions can be primary lesions, secondary lesions, or special lesions. Primary lesions refer to the most characteristic, representative, or native appearance of skin lesions. Secondary lesions occur due to the effect of exogenous factors or temporal changes that evolve during the course of a skin disease. Special lesions are characteristic lesions which are specific for certain diseases. Next. So the primary skin lesions are macule, patch, papule, plaque, nodule, vesicle, bulla, pustule, wheal. Next. So a macule, it is a flat, non-palpable, circumscribed lesion which differs in color from the surrounding skin. The size of a macule is less than 1 cm in diameter and it is often hypo or hyperpigmented but can be also of other colors like pink, red or violet, and the shape depends on the underlying diagnosis. Next, patch. Patch is nothing but a macule which is more than 1 cm in size. It is also flat and non-palpable. Next. Coming to papule. Papule is an elevated, palpable, circumscribed lesion which is less than 1 cm in diameter. The elevation may be due to increased thickness of the epidermis or because of the cells or deposits within the dermis. It may have secondary changes like scales, crest, etc. And papule can be flat top as in lichen planus, dome shaped or umbilicated as in molluscum, smooth or verrucous. Plaque is a papule or it's an elevated lesion which is more than 1 cm in diameter. And here also elevation may be due to increased thickness of epidermis or cells or deposits within the dermis, and it may also have secondary changes. Occasionally, a plaque may be palpable, but it is not elevated, for example, in morphia. Then nodule is a palpable, circumscribed lesion of size more than 1 cm. Nodule is a primary lesion which cannot be differentiated on inspection. It requires palpation to differentiate a nodule from a papule or plaque. And it may be compressible, soft, rubbery or firm in palpation, and it involves the dermis or the underlying subcutaneous. The greatest portion may be beneath the skin surface or it may be exophytic. Next is wheal. It is a transient elevation of the skin due to dermal edema. It is often pale at center and with an erythematous rim. Then vesicle is an elevated circumscribed lesion which is less than 1 cm in diameter, filled with fluid. This fluid may be clear, serous or hemorrhagic, and it may become pustule, umbilicated or an erosion. Then bulla. Bulla is an elevated circumscribed lesion which is more than 1 cm in diameter. It is essentially a vesicle which is more than 1 cm in diameter. It is also fluid filled and may become an erosion. Then pustule. It is an elevated circumscribed lesion which is less than 1 cm in diameter, and from its onset itself it is filled with purulent material, and this pus may be infectious or sterile. Coming to secondary skin lesions, this include crust, scale, fissure, excoriation, erosion, ulceration, infarct, atrophy, lichenification. So crust, it is a dried serum, blood or pus on the surface of skin, and it may include bacteria, usually staphylococci. Then scale, it is a hyperkeratotic lesion. Scales are due to accumulation of stratum corneum due to increased proliferation or delayed desquamation. In ichthyosis, it represents a primary lesion rather than a secondary feature. linear clefts in the skin which are often painful and results from marked drying, skin thickening and loss of elasticity. Excoriation. Excoriation occurs due to exogenous injury to all or part of the epidermis. It may be linear or punctuate. Erosion is a partial loss of epidermis. It occurs as a superficial, moist, oozing or crusted lesion. Ulceration. Ulceration is a full thickness loss of epidermis. It may have loss of dermis or even subcutaneous. The size, shape and depth should be described as well as the characteristics of the border, base and surrounding skin. Ulcer, since it is deep, usually heals with a scar. Infarct, it occurs due to ischemia of tissue. The color of an infarct may vary from grey-white to purple to black. Atrophy. Atrophy can be epidermal atrophy or dermal atrophy. Epidermal atrophy is due to thinning of epidermis leading to wrinkling or a shiny appearance. Dermal atrophy is due to loss of dermal collagen or elastin leading to a depression. Lichenification. Lichenification involves three features. It's a triad of increased skin thickening, prominent skin markings and dyspigmentation, whether hypo or hyperpigmentation. And it often occurs due to chronic itching or rubbing. Coming to special skin lesions, this involves characteristic lesions which are specific to a particular disease. For example, burrow in scabies, comedone in acne, in milium, telangiectasia, target lesions as seen in erythema multiforme, calcinosis, sinus. Then coming to the shape of the lesions can show different shape like discoid, petaloid, arcuate, annular, polycyclic, livido, reticulate, target, stellate, digitate, linear, serpiginous or hold. So discoid is a filled circle as seen in discoid eczema, DLE, etc. Petaloid lesions are discoid lesions which have merged together like in seborrheic dermatitis of the trunk. Arcuate lesions are incomplete circles as seen in urticaria. Annular lesions are circles with different center compared to the rim. It is seen in tinea corporis, granuloma annulare, etc. Polycyclic are circles which have merged together. It may be seen in psoriasis or tinea corporis. Livido are chicken white criss-cross pattern. It is seen in erythema abigne, polyarthritis nodosa, etc. Reticulate lesions are shape is fine lace-like pattern which is seen in oral lichen planus. Then target lesions are multiple concentric rings which is seen in erythema multiforme. Stellate is star-shaped, seen in lesions of meningococcal septicemia. Digitate are finger-shaped which is seen in chronic superficial dermatosis. Linear lesions are straight line which are seen usually in Koebner reaction as a reaction to a scratch in lichen planus or psoriasis. Then serpiginous is snake-like, seen in cutaneous lava migrans. Hold is swirling pattern which may be seen in epidermal nevi, late stage of incontinentia pigmented. Next. Distribution of lesions. The major distribution pattern may be defined like disseminated versus localized or solitary, unilateral or bilateral, symmetric or asymmetric, whether in sun-exposed sites or sun-protected sites, flexural or extensor, intertriginous or large body folds, whether acral, palmoplantar, seborrheic region, periorificial or mucosal. It can also be, distribution can also be, also involve linear, which is also considered a configuration. Coming to some of the examples of a description of lesion. For papules, example scabies. A scabies, characteristic scabies lesion can be described as multiple erythematous papules distributed over the body with predilection to finger webs, wrist, axilla, breast, umbilicus and genitals associated with excoriations, erosions and crusting. Plaques, example psoriasis. A psoriasis lesion can be described as multiple well-defined erythematous annular plaques of size, say varying from 3 to 10 cm, distributed predominantly over the extensor aspects of the body, elbows and knees covered with silvery white scales. The scales are usually loosely adherent scales, which on removal can show pinpoint bleeding. Bullae, example pemphigus vulgaris. Pemphigus vulgaris lesions may be multiple flaccid bullae of size, say 2 cm to 5 cm, with serous fluid which rupture easily, leaving behind crusted erosions, may be distributed on face, trunk and extremities. Next, coming to the palpation of lesions, we have to look for whether the lesion is palpable or not, the temperature of the lesion, whether it is raised or not, whether the lesion is tender. Then palpation helps in differentiating a papule or plaque from a nodule. A diagnosis of a nodule should be made only after palpation because nodule goes deep into the dermis or subcutis. Then look for surface texture and scaling. If there is no visible scales on inspection, we have to do scratching to elicit a scale. Then look for the thickness, induration, consistency and fluctuation of the lesion if there is any. Then look whether for the mobility of the lesion, whether the lesion is mobile or it is fixed to an underlying structure. Then in case of an ulcer, look for the base of the lesion. The base of an ulcer is always a palpatory finding. We can see, on inspection we can see the floor of the ulcer, but the base, that is the structure on which the ulcer lies, should be examined by palpation. Then when there is an erythema or purpura or ecchymosis, always look for blanchability, whether it is blanchable or not. Then for malignancy, it is very important to look for the draining lymph nodes. Then special signs, on palpation we have to look for the special signs depending on the lesions. For example, in immunoglobulous diseases, look for Nikolsky signs, Ashby-Hansen's, etc. Thank you.